the Tennessee Justice Center, Tennessee Valley Unitarian Universalist Church, Claire and Sullivan and Mark Brooks. Our silver sponsors include the Cherokee Health Systems, Knoxville Local Organizing Group of THCC, Barbara Reynolds, and the Peacemaking Committee of the Presbytery of East Tennessee. We also have a list of several bronze level sponsors. Where are they at? And we want to wish a very hearty thank you to all of them. So thank you to all of our very generous sponsors. Without you, we could not provide the conference and do our work. Also, thank you to the participants. Without you, there would be no purpose for the conference. So thank you. Now to introduce today's conference is THCC's interim executive director, Claire Sullivan.
Hi, thank you, Randall. Some of you are probably veterans of our annual health policy conferences, but I wanted, I suspect that some of you are new, and I just wanted to give you a little bit of background. Ellie, could you put this slide up about the past conferences? There you go, thank you. All of our conferences have been the product of a lot of planning from members of our board and our volunteers. I wanted to give you an idea of what some of our topics have been like in the past. A lot of the conferences have focused on key health issues that have been before our nation, as well as our own anticipation of what some of the issues will be in the state legislature in the coming year. And for many years, the focus has been on explaining and protecting and improving the Affordable Care Act, as well as the need to try to close the coverage gap for over 400,000 Tennesseans in our state. And those are still very critical issues for the Tennessee Healthcare Campaign. In past years, if you'd been at our conferences, you would have seen and met our conference committee members and our board. We would have been doing registration at the door, moving tables and chairs around, making coffee, serving snacks and lunch, and passing out evaluations, monitoring our famous silent auctions. But this year, as Margaret said, is our very first virtual public education program. And we're excited about it, but we do miss the opportunity to meet you all in person. However, since we're not in person, I do want to introduce the committee to you, and that's the next slide. So you've met Margaret Axelrod, who's Dr. Margaret Axelrod, who's our moderator for this and several of the other sessions. Behind the scenes, as Margaret mentioned, is Allie Halton-Stoop, who is one of the co-chairs of the committee. Soon you'll meet Jacqueline Favors, who not only set up our Zoom mechanics and coordinated this session, co-chaired all the sessions with Allie, but is also presenting today. You've met Randall Rice, who just started us off. And in the breakout sessions today, you'll be introduced to Chanda Dunn and Jose Davila. Tony Garr has done a yeoman's task of pulling together our sponsors this year. That's me in a pre-COVID haircut. And you'll also, I hope, get to meet Michael Heinrich, who is here with us, although not pictured. Next slide, please. Next slide. No, never mind. Go back to that one. Sorry. Okay. This is the outline of our virtual conference series. And I just wanted to share that we found it really hard this year to choose a theme because it's been such a turbulent and troubling year for so many reasons. We landed on achieving health equity for all Tennesseans in an era of change. And I just wanted to take a minute to share that process. It was clear to us that COVID had undeniably changed and disrupted our family, social, and work lives, and that it also revealed deep flaws in our healthcare system and our government's responses, and that we were not going to get the spread of that virus under control anytime soon. However, we didn't want to focus just primarily on COVID. Our board had just approved a collective statement on racism and healthcare in recognition of the powerful Black Lives Matter movement across our state and nation, and the realities exposed by COVID to the world of the deep and persistent racial and economic disparities in our society that are responsible for the continuing and growing inequities in death and disability being experienced by minority communities. Those are the conditions that we also wanted to focus on, and those are the conditions that we need to change. In that statement, which you can see on our website, we conclude that by committing ourselves to continuing our own education of our board and staff around the issues of systemic racism in our healthcare system and in our society, we can begin to move forward. And that is why this session is so central to our work in the coming decade. So we're very honored to have a thoughtful panel of young Black health professionals who have already provided critical leadership on these issues in our state. And we're also honored to have those of you here with us today participating in these discussions. I'm going to turn the session over to our moderator, Margaret. She'll go over some housekeeping issues and then introduce our panel, and we'll get started. Thank you so much. Margaret.
Thank you. Thank you, Claire. So Allie, if you'll just go to the next slide, I'm going to go over some logistics of Zoom, as this is something we've all sort of had to figure out together in the last couple of months. So one thing that we recommend is that you keep your Zoom in speaker view. If you don't know where this is, if you move your mouse to the top right corner of your screen, you'll see something that says view, and you can select speaker view. That way you'll always see the person who is speaking at the time, and you can keep an eye on our panelists. The other critical thing is the toolbar at the bottom, and I've highlighted the two most important things. So there's one, the mute button, so please keep yourself on mute except for during the breakout discussions later in the session, and the chat box. So this chat box is where you'll put all of your questions. If you have questions about Zoom or you're having an issue, or importantly, questions for our panelists and how you'll stay engaged with us throughout the session. So click the chat box there to ask your questions. You can go to the next slide, Allie. The other important note is that this session will be recorded and will be posted on our website later. So again, please keep your microphone on mute and keep an eye on the chat box. Also, if you do not see the chat box down below, Allie, you can click one further. You'll have a little ... that says more, and you can click that ... box and the chat should come up under there. And you'll be able to see that. So, and if you have any questions about Zoom now, this would be a great time to put them in the chat box. Otherwise, I'll keep going and introduce our first panelist. So as Claire alluded to, I'm absolutely thrilled to introduce our first speaker for the day. It's really an honor, I think, for me to get to introduce Jacqueline. So Jacqueline Favors is the Director of Community Engagement for the national nonprofit organization Health Leads, where she works at the intersection of healthcare and health equity, aiming to ensure every person has the ability to achieve health with dignity. Jacqueline graduated magna cum laude from Fisk University with a bachelor's degree in biology and received her master's of public health from Tennessee State University. She has over 7 years of academic, community engaged, and health disparities research. Jacqueline has served as the co-chair of the NAACP Nashville Branch Health Committee and as a mentor for the TN Achieves program and as an ambassador for the nonprofit Black Ladies in Public Health. We are also incredibly lucky at THCC to have snagged Jacqueline to serve on our board of directors and also as the co-chair for this conference series. Thank you so much for presenting today, Jacqueline.
Thank you so much, Margaret. I really appreciate you and also the Tennessee Healthcare Campaign for having me here today and inviting me to speak on what health equity is. And I'm definitely excited to share because this is my wheelhouse, and public health gets me all riled up. And just hearing you talk about my background, it's funny because of where I'm going to start off today. But yes, I am a public health professional through and through. And as a public health professional, I make the health of communities my business. And before I do that, next slide, please. I do want to start with a story. And who you've seen before you today is a little girl who had dreams. And if you don't recognize her already, it's me. But this young girl had dreams of equality. And if you would have asked this young girl, who's about 5 at the time, what she wanted to be when she grew up, she would have said that she wanted to be the leader of the free world. And some may chuckle at that, but as a young girl who thought and believed in the ideals of American ideals of justice, liberty, equality for all, I really did believe that I could grow up and do anything I wanted to do, be anything I wanted to be. And fast forward a little bit, a few years when I was in high school, I had a math teacher actually that gave me a very important assignment that taught me, and very timely assignment that taught me a lot about life. And the assignment was to figure out a couple of careers that we wanted to do ideally. And luckily through that time, every time I told someone I wanted to be the president, everyone always said, no, you're going to be a doctor, you're going to be a doctor. So at that time I decided, well, I'll look up what does it take to be an MD, and what would it take to be my next favorite thing at the time, because I was really an admirer of my math teacher and his ability to teach. I thought I would look up being a math teacher. And it was at that time that as I began to look up, and if you've ever looked up the difference between income, years of schooling, there's some differences there. And it was that time in my mind that I realized 2 jobs that I thought or held fairly equal to myself were actually not seen equal at all to the world. And so fast forward a little bit further to the time when I'm about 22, I found myself in unfortunate circumstance. And like many of my classmates, which I felt was kind of weird, we were struggling with finding access to healthcare. And I found myself without healthcare insurance. And oftentimes I saw my classmates relying on local clinics, having to pay copays. And if you know anything about being a student that doesn't have much support, you don't really want to pay for many things because, and especially going to the doctor, because going to the doctor meant money. And if anything, we would just try not to get sick or hold off a little bit longer. And as a as a student that was working part-time, trying to survive off a work study, I definitely wasn't trying to go to the doctor and didn't have the ability to afford healthcare, and fell into this gap where I wasn't supported by other resources or other means of getting healthcare. And so I believe it was really at that time that those lessons all kind of piled up for me and taught me my next point. Next slide, please, which is about equality, the difference between equality and equity. And what you'll see here is a image that you've probably seen many times, and maybe you haven't, but it's often used in the public health world to describe the difference between equality and equity, because it shows 3 individuals that are watching a baseball game over a fence. And what's more American than a baseball game and watching it over a fence, right? So this picture actually shows on the left-hand side equality and what equality looks like in this particular context. If every individual is given an equal box, they don't have the same access to watch the game. Whereas if they're given on the right-hand side boxes that fit their situation and fit their needs, everyone's able to access the game. And so that's the thing that that's the point that I want to make here about equality and equity. When we're working from a point of equality or from a lens of equality, saying that everyone deserves the same thing, we're giving them exactly that. And we're also assuming that everyone is starting from the same place. And the difference there is that with equity, we realize that everyone doesn't start from the same place in life. And sometimes there's a need for us to give more or a little less, depending on where people are starting. And an example there is going back to my story. As I was an adult, not able to afford health insurance, again, I was falling into a gap where there was equality of things, where there was healthcare insurance, there were resources out there, but I was not able to access them because of equity issues. And I want to go to the next slide. So, talking about health equity and what's this whole thing about health equity? And I'm showing you another image that takes another situation to demonstrate equality versus equity. But also, I want to describe to you the idea of health equity. And health equity is a term that began to be popular because it described what was possible when we didn't have disparities or inequalities or inequities. And so I describe health equity as the goal or the vision for public health. We want a world that sees equality as possible, that aims for equal opportunity and makes sure that every person has the opportunity to access health. And in the image, it shows you that every person on the top layer doesn't start at the same place because every person did not start with a disability. And this individual on the right hand side, you see, is in a wheelchair and unable to ride a bike. And what we know is that we have enough resources and technology today for even a person who may have be physically disabled to be able to enjoy the pleasure of riding a bike. And so through addressing those things, what are the social and environmental things? Things like income, what neighborhoods we live in, education levels, those things are actually predicting what our health outcomes are. And with health equity, this shows that we want to change those things. And it's really important for us to know what causes health in the first place if we want to address those things. Next slide, please. And so, in the next slide, we see that you see an individual, and we see that there are multiple things that contribute to an individual's health and a community's health. And so I have the tagline there that social and environmental factors determine 40% of an individual's health. And it's actually 50% as we go through this diagram, you'll see. But on the top half, you'll see that there are social economic factors, like I just described: education, job status, family, social support, income, and community, that makes a difference in whether a person is healthy or not. Those things not only determine a person's health, but they also determine how a person will interact with the healthcare system as well. And so, looking further down, if we go down below and look at the healthcare piece, you'll see that that contributes 20%. And so when we think of all these things together, social economic factors, the physical environment that someone is in, the neighborhood that they're living in, the city that they're in, the zip code that they live in, and also healthcare access, those things begin to add up, and we realize that it's not just health behaviors that contributes to a person's health outcomes. And for so long, I think in public health, we focused on just trying to get people to make the right decisions, and we were wondering what's not working. And we realized that there are these forces that are coming against, and I think more clearly now, by the injustices that are happening in our society, that there are these forces that push back against an individual's health, even if they are attempting to make healthy behavior choices. And some of those things keep them from making those choices. And I want to dive a little bit further into social and economic factors and the environmental factors quickly and just provide an example. And so you see here the social economic factors again, they're just blown up. And this is an image from Blue Cross Blue Shield. But I like this image because it really simplifies the 5 categories of the social environmental factors that are determining our health. And I can go back to that example of being a student, being a college student with a part-time job, not being able to afford health insurance, but I can also provide an example of a father who may live in Tennessee and have to commute long distances to work and may have a chest pain or some pain come up in their body and not really feel like it's a priority because of the other issues they're dealing with, such as work priorities, family priorities. And those things tend to keep us making different health choices. So instead of going to the doctor, that individual probably waits a little bit longer and that health issue worsens. So that's just another example. I could also talk about having living wage, the rate of cost burden in urban areas, having stable housing, reliable transportation in rural areas, and many, many more examples that contribute that are to these different categories that are listed here. But as I'm saying, the point I want to make here is that these social economic factors drive health in a positive or negative direction based on whether or not they exist. Of course, for individuals who are able to take these things for granted, they don't have to worry about whether or not there's a park in the neighborhood that's safe for them to play at or to take their kids to play at, not worrying about whether or not they would miss pay by going to the doctor. And those are things that are causing people to continue to struggle with their health and continue to struggle managing their health. And because of that, we know, next slide, that instead of health equity, what we actually have are health inequities. And these are the things that we are working against. As mentioned here in the definition, excuse me, um, health inequities are those things that are social and economic, like I just mentioned, but they also are systematic and they are avoidable and unjust and unactionable. And they're due, as we know in this country, because we didn't all start off at an equal place. And in our country, certain systems, in particular health, was set up in a way where there was an unequal distribution of resources to begin with. And because of that, that cycle continues to make the inequities systemic. And again, going back to the things that these are the things that people are unable to grasp, even if they are making the right behavior decisions or behavior choices, they're unable to access these things because of the inequities and unequal distribution of resources. And next slide, please. And so it's, again, I think it's really important that we talk about this definition of inequities and call out inequities directly. And that's what it means to be leading with a health equity lens. And once and when we address these systemic inequities that keep us from having a healthier community, we'll be able to make action. And so again, going back to this slide, and you see the tree that I have here, it's a barren tree. And this is what the systemic inequities continue to make our society into a cycle of like a barren tree that is not able to produce fruit or make progress on health equity because of these systemic issues. And as I mentioned before, by us being able to identify these issues and call them out specifically and acknowledge that we are not all starting from the same place when it comes to health and the different determinants that go into our health outcomes, we will continue to be in the health statistics that we have now. Tennessee is a state that's very unique because it is a mix of urban and rural. But we have a high number of rural individuals that live in low income situations or environments that are under resourced. And because of that, there's systemic issues around living in a rural area. And those things we have to acknowledge. And if we don't acknowledge those things, we continue to be in the 40s on just about every disparity that you would list, or that a health professional would list. Tennessee would not be doing as good as it could possibly be doing, and definitely not on par with national. So we want to go on to the next slide, because you're probably wondering, why do all these things matter? And why it matters, again, is because we want to move forward. Once we're able to acknowledge what health equity is as a collective and as a whole, we're able to get over differences. We're able to advocate for vulnerable communities. We're able to support equitable policies and fully understand the common goal that we're all working towards. And so some of the things that I've listed here are healthier policies, healthier communities. If I was to ask anyone here today, I'm sure that if I asked you if you wanted better healthcare, you'd probably say yes. And I could guarantee you that if we as a whole, as a community, as a state, and Tennesseans, if we work together to have everyone understand the common goal for health equity, then ultimately there will be an altruistic effect that everyone in the community would be able to have an improvement in their health care. And so I also mentioned here less suffering from peers and family. And I mentioned that specifically because of COVID. And I think that that's what shined on us so much in 2020, is that because we continue to have the same systemic issues that we state that we might be addressing, but don't put action towards and come together to work together as a community, then we continue to see that individuals will suffer when there's a crisis. Our peers, our family, our friends, and hopefully not, but quite possibly could be ourselves. So when we do this, we're able to create change. And just going to the next slide, I bring back up this image of health equity. And you see in the third panel that the fence is gone. And so I bring up this image and want to leave with this image because I started off with a story of a little girl who was dreaming and had a vision of something. And the story and the tagline here says, don't just tell a different version of the same story, change the story. And so what I would want for my future and for the little girl that was coming after me is to not tell a different version of that same story, but to be able to change the story, that we all have equality, and equality through achieving, I apologize, we all have equality through being able to address inequities. And as you see in the third picture there, who knows what's possible? We might even remove all the barriers to allow everyone to have access to the game. So I will stop there and take any questions.
Thank you so much for that presentation, Jacqueline. If there are questions for Jacqueline, please put them in the chat box now. Jacqueline, I was wondering if you might talk a little bit about what you think it would look like for us to do this, the way you're talking about focusing more on health equity, and what it would look like in practice for people. And I feel free to answer that on either, a systems level or an individual level, what people in the conference can do to think about how health equity would affect their lives.
Right. Well, I talk to a lot of health professionals, so I'll try to address it on like an individual level or a more local community level, and also at a national level. And I think that on a more individual level, we need to be more understanding of what communities are going through. Oftentimes, when we're trained, just like I was when I was in high school, I was thinking that I was trained to see certain things, but those things aren't always the most important things. And sometimes it just takes one person asking you the right question for you to fully see what's most important. And I think that sometimes as people that are helping navigate folks to different services or helping provide services to individuals, we might sometimes question why they're in that situation or why they're not doing what's necessary for them to have better better health. But I also think that we need to acknowledge what has happened to individuals and the point at which they started from, to get to that point in order to help us be better providers of care on an individual level. I think on a systems level, we have to be very specific about when we're writing policies, when we're writing rules, about who we are addressing those things for. As you see in the fence image, if we give everyone the same thing, if we provide equal policies, then those policies are not going to be what everyone needs. What we need to be doing is providing equitable policies. And the way that we get equitable policies is that we begin talking to, we begin engaging, we begin getting to know those vulnerable communities that we're drafting policies to help. So I'll stop there.
Oh, well, thank you for that answer. I think there are two related questions here. Barbara Clinton asks, is there one particular aspect of health outcomes that particularly troubles you in terms of lack of equity? And I think this is a related question too. Jose asked, how does the US fare on health equity relative to other industrialized countries?
Okay, well, to take the first, well, I'll answer Jose's question first. But Jose, you might know and others might know, the United States does not fare too well as it relates to other countries because of the amount of money we spend on healthcare. And that's always that's a whole nother can of worms, of course, but the amount of money that we spend on healthcare, if we were actually making progress, it should seem that we would have the best care. We wouldn't have anyone suffering at all. But we actually have quite a high spending in our healthcare system, and in compared to other countries who are spending less and even in some instances providing healthcare as a birthright or to all citizens of their country, they have better health outcomes, of course, because individuals are not worrying about that initial encounter with the doctor, right? They're able to go and get primary health care. Of course, they have to pay for specialty services, but I think that the ability for individuals to have that initial access point, that primary care visit, is very important. And so I guess going into the second question of, is there one particular piece that really troubles me? I think it's that piece. It's the fact that people can't wake up or even be born and just know automatically that they have health care or they have access to quality health care, and that in our country it's more about having to have money or having to have a certain social status to be able to get quality care. And so that really sends a bad message to individuals who don't have money. It tells them, you shouldn't get sick. But we know that that's not the case. People will still get sick, and we've seen that with COVID.
Thanks, Jacqueline. I think in the interest of time, I'm going to move on to our next speaker, but if we have time a little bit later, maybe we can circle back to Tony's question. I think it could be relevant for more of our panel as well. So we're going to move on to our next speaker now. I'm really excited. Our next speaker is Kanika Young. She is the Senior Director of Health Policy and Advocacy at the Tennessee Justice Center. Kanika is a lawyer and health policy advocate who frequently speaks on issues concerning access to healthcare, focusing on the role of public benefit programs to help people who lack adequate resources to meet their needs. She graduated from Florida A&M University with a degree in political science and earned her Juris Doctor degree from Tulane University Law School. In her role at the Tennessee Justice Center, she leads efforts to build a movement across the state to protect and strengthen safety nets for children, families, seniors, people with disabilities, and move towards the equitable allocation of resources to all Tennesseans. Kanika was also recently appointed by Mayor Cooper to the Healthy Nashville Leadership Council. Thank you for sharing your work with us today, Kanika.
Thank you so much for the introduction. Thanks for having me. Good morning, everybody, on this crisp fall morning. I hope you can get out after this and enjoy the good weather we're having. So for my presentation today, I want to start with the premise that the analysis of health disparities must be examined through the lens of racism. Racism exists. I know more and more these days there are disputes about what's true and what's fake news, but I'm stating this as a matter of fact and not opinion. Racism shows up in various ways and in various systems. And so with health disparities, they should be considered within the context of health inequities and the practices and policies that embody and reflect racism. One of the primary health inequities that causes poor health outcomes for Black people is the denial of access to healthcare because of political choices made by state leaders. And another factor is poor quality of care that is often linked to providers' implicit racial bias. The pandemic that we're living through has opened a lot of people's eyes to how racism shows up in our society. Some people have called the novel coronavirus a great equalizer, in that everyone is affected, but not everyone is affected to the same degree. Most people have seen news reports about disproportionately high rates of cases, hospitalizations, and deaths among Black people. And I know Monique Anthony is going to talk about health disparities and the impact of COVID-19, so I won't dwell on the pandemic, but it provides important context for this discussion. And what I want to talk about are the underlying reasons for these disparities and what can be done about them, specifically through expanding health coverage. So on this slide, I want to use this to do a little bit of level setting and consider the differences between health disparities and health inequities. So on the left, you see health disparities, and that I define as different groups having different health outcomes. So there are higher rates of infant mortality and maternal mortality, specifically for Black women and Black infants. Black women are 3 times more likely to die from pregnancy-related complications, and twice as likely to lose an infant within the first year of life than white women. Also, you see higher rates of chronic conditions and diseases among the Black community and other communities of color. For example, obesity and asthma. And it's notable because obesity is one of the really important predictors of severe coronavirus illness. And so when you have higher rates of obesity, you see more serious illness from that one disease in particular. And it's really alarming because the US has the highest obesity rate, or one of the highest obesity rates in the world. And another is asthma. And considering this also raises environmental factors. It's more likely that people of color will live in neighborhoods that have higher rates of pollution due to segregation and other factors such as environmental racism, where it's more likely to have a pollution producing element such as a factory or other stressors, climate stressors located in low income communities. And so this is another way that people of color are disproportionately impacted by policy decisions. And then lower life expectancy. This is a really significant health disparity in that Black people have a lower life expectancy on average than white people. And there are lots of factors that play into that. So all of these are just examples of health disparities, the idea that certain people have different health outcomes compared to other races. Then on the right side, we see health inequities. This is defined as different groups having different access to resources. And Jacqueline talked a lot about social determinants of health, so you can recognize this list. And the point that I really want to iterate is that all of these resources are systems that are impacted by racism. Our education system, we still have segregated schools in our country. Housing, we still live in largely segregated neighborhoods in a lot of places. Food, we know that in low income neighborhoods, access to grocery stores with fresh fruits and meats is an issue. Transportation, our city, if you're located in Nashville, we've seen our share of struggles with issues related to mass transit and the push against providing public transit that is more accessible and convenient and affordable for people. That is an issue that disproportionately impacts people of color who rely on public transportation to a greater extent. Employment. There are countless examples of discrimination in employment dating back to the beginnings of this country in terms of people not being permitted to work in certain fields and being steered towards more low wage paying jobs. And then healthcare. That's where we want to spend a lot of our focus today in terms of how racism shows up in our healthcare system in terms of access for people of color in our country. And I would like to also just mention here that poverty alone is not the issue here. There's more to this problem of having inequitable distribution of resources. And there's a body of research that talks about something called the weathering hypothesis. This was first introduced in 1992 by Arlene Geronimus, and it states that the health of African-American women in particular may begin to deteriorate in early adulthood as a physical consequence of cumulative socioeconomic disadvantage. The weathering hypothesis has been cited extensively, and further studies have revealed that there's evidence that poverty alone is not responsible for the racial inequities in health that exist between Black and white Americans. And so these stressors, including racial discrimination and its attendant consequences, can cause a type of accelerated aging that then shows up in the health disparities that we note for different races. If we could go to the next slide. So the flip side of health disparities is health equity. And Jacqueline did a great job of explaining the difference between equality and equity. So I won't linger on this topic, but to answer the question of what's needed to be healthy, we must consider social determinants of health. And we know that equality is not the answer for the reasons that Jacqueline has already explained. So we need to move towards equity and really understanding the social determinants that need to be addressed in order to advance equity. Next slide, please. So again, with social determinants of health, we're talking about things like education, healthcare, environment or neighborhood, economic stability, and social and community context. They all come together to influence our health. And this quote from Howard Koh, which is health is much more than an interaction in a provider's office. Health starts where people live, labor, learn, play, and pray. This was made following a speech by Dr. Jack Geiger, who is a co-founder of the Community Health Center movement in our country. Dr. Geiger was first exposed to the Community Health Center model while visiting South Africa, and then he brought that model to Mississippi, where he worked in the 1960s in the second poorest county in the country. And that's where he and his colleagues worked largely on living conditions and on addressing malnourishment to provide community health and improve health outcomes for the community. So social determinants of health are inextricably linked to racism. We see a lasting impact of policies such as government redlining that were in place in the 1930s, under which Black communities were excluded from mortgage lending programs and business investment. And that means that even to this day, many Black residents live in segregated neighborhoods that lack job opportunities. They lack adequately funded schools, they lack stable housing, they lack grocery stores with healthy food and other resources. And that's why your zip code often predicts your health outcomes. So considering social determinants of health forces us to re-examine the role of personal responsibility or personal behavior in health outcomes. People can only choose from the choices that are available to them. And so addressing these issues requires looking at systems and how policies actually impact people's lives. Next slide. So as a result of our failure to invest in addressing social needs, we've seen health inequities increase at a huge cost. Health inequities actually, it's been estimated to cost our healthcare system $93 billion. The economic costs of health inequities are around 135 billion. And by 2050, fixing the problem would actually add $230 billion annually to the US economy. So for people who care more about money than people, this is something that really should stand out to them and really understand that we're losing out by not addressing these issues. We also need to consider the changing demographics of our country. In 2012, the majority of births were of babies of color. Today, the majority of kids under age 10 are of color. In 2020, the majority of people 18 and under are of color. And by 2045, it's projected that our country will be majority of people of color. And so it's imperative that we achieve health equity to avoid ongoing and repeated public health crises. Next slide, please. So let's take a step back to discuss how we got to this place of health inequities in our US healthcare system. So COVID-19 isn't the first disease to have a disproportionate impact on Black Americans. There was a smallpox epidemic in the South and around the time of the Civil War. And the Freedmen's Bureau was actually, or the medical division of the Freedmen's Bureau was our country's first federal healthcare program. It was established to provide healthcare and other resources to the Black Americans at that time, but also to poor white people in the South. But this Freedmen's Bureau was woefully understaffed and under-resourced. And so there was no real opportunity for poor people, and specifically people of color, Black people, to get the health care and resources that they needed in terms of sanitary living conditions, access to food, to achieve nutrition and what have you. And so health was an issue just starting right out of the gate for Black people in this country. Fast forward a bit to the 1930s and 40s, the country was struggling to recover from the Great Depression, and President Truman stepped up with the New Deal policies. But farm and domestic workers, which more than half of the nation's Black workforce were in those two industries at the time, they were excluded from New Deal policies. That meant no Social Security, no fair labor standards, including minimum wage or an 8-hour workday, and state control of federal dollars allowed discrimination to continue unchecked. In 1945, President Truman proposed a universal national health insurance program. And notably, the American Medical Association, which at that time excluded Black doctors from being members, opposed this universal national health insurance program, calling it socialism and scaring people into thinking that it would disrupt their relationships with their providers and cause them to basically have poorer health care. And I would recommend for folks who are interested in learning a little bit more about that to check out the New York Times article entitled, "Why Doesn't the United States Have Universal Health Care? The answer has everything to do with race." It does a great job of laying out things like the Hill-Burton Act and how it provided federal grants for hospital construction to communities in need. And it particularly gave funding priority to rural areas, many of them being in the South. But it also ensured that states control the disbursement of funds and could segregate the facilities that were built with that funding. And so with the opposition to the National Health Insurance Program, things sort of continued unchecked in terms of people not having access to health insurance. And private health insurance plans became really popular, particularly with labor unions who were able to collectively bargain and ensure benefits for their members. But notably, many Black people were barred from even joining these labor unions. And so there was another, example of how systems were set up and policies were implemented that oppressed Black people and kept them from being able to access this valuable resources. So when you predicate access to medical care on a system of employer-based insurance, and you know that employer-based insurance is tied to those jobs that bar Black people, then it can't come as a surprise that there are lower rates of insurance for people of color, for Black people. So creating a system that ties health coverage to employment and then denying those types of employments of Black people has allowed racial health disparities to persist. So by the almost 1950 and 1948, President Truman won re-election and revived the call for health insurance, for a national health insurance program. Again, the American Medical Association opposed it, but this time the National Medical Association stepped up to counter that message. And the National Medical Association was comprised of Black doctors and medical students, which again, they were not allowed to join the AMA, so they created the NMA. The NMA stepped up and were pushing for a federal healthcare system for all citizens. They noted the segregated facilities, the unequal resources that were provided, the fact that Black doctors and nurses were not allowed to train or to practice on certain white facilities. And so this unequal two-tier system was very well known to them. And so they were pushing for a federal healthcare system to create more equity in our healthcare delivery system. And they were successful in their counter message campaign. And that led to the creation of our Medicare and Medicaid programs. Now, these programs were great on paper, but they didn't actually make progress towards achieving equity because facilities could choose not to participate. But in 1964, the Civil Rights Act outlawed segregation for any entity receiving federal funds. And so that was crucial because the Medicare and Medicaid programs were federal funds. And if hospitals participated, they had to agree to desegregate. And so that was instrumental in bringing about access to healthcare for a lot of people of color. It wasn't a silver bullet because not everyone qualifies for Medicare and Medicaid, but it was significant advancement towards expanding access. So next slide, please. There are longstanding barriers playing out today that are a result of this haphazard healthcare system that we've allowed to continue. We know that there was lots of misinformation, particularly when the pandemic first started. There were rumors that Black people were immune and they weren't going to, be impacted by this disease, which was absolutely not true. We have seen initial indications that doctors are less likely to refer African Americans for testing and for other interventions because of these really misguided beliefs about Black people not feeling pain or that they're impacted in some different physiological way than white people in response to different diseases. In fact, I've seen at least one study that reports physicians believe Black people have a higher pain tolerance and that there are physical differences between Blacks and whites that are just not true. We've also noted that there is a mistrust of our healthcare system because of medical assaults that have been noted in the past that have been inflicted upon Black people. And I've just listed, an example here, the Tuskegee syphilis research, and that has added to Black Americans' mistrust of the healthcare system. And there are ongoing examples of that, which is why we are concerned about the distribution of a vaccine if it were developed for COVID-19 and whether people would actually be vaccinated. Inadequate access to resources to meet basic needs. This was noted from the very beginning in terms of the impact of the smallpox epidemic on Black people who were not able to access safe living conditions or a living wage or nutrition, et cetera. So all of these basic needs that go unmet continue to be a barrier for people of color. Also, in our overrepresentation in the so-called essential workforce, this is another reason that we see these disparities, specifically with the COVID-19 pandemic, because more Black people are in those types of jobs that require them to still show up and interact with the public, and they're not able to telecommute as some people can and are able to isolate themselves and avoid exposure to the virus. And also in unemployment, this remains a barrier for people of color in that just in recently during this pandemic, as many as I can't recall the last counts, but at some point about 22 million people in the US had lost their jobs, and roughly the number of positions that had been created in the past decade in terms of job growth. And so there are new numbers coming out periodically about the unemployment rate, but what's not often mentioned is that the unemployment rate among Black people is always higher than white people. And you can, speculate as to the reasons for that, but the fact remains that because health insurance is often tied to employment, when you have higher unemployment rates, you have a disparate impact on Black people as a result, if they even were able to get employer-sponsored insurance with that job. And so it's also estimated that as many as 12 million people in the US have lost their employer-sponsored insurance as a result of the economic downturn. Next slide. So to address health disparities and advance health equity, we want to drill down on the lack of access to healthcare. Black Americans are 1.5 times more likely to be uninsured than white Americans, and less than half of private sector employers offer health insurance to employees. So this is significant. Also, it's significant that healthcare costs are unaffordable. So if you don't have health insurance, then you really are unable to access healthcare and specifically preventative services that are so important to address issues early on before they get out of hand. And so just tracking uninsured rates as it relates to race and ethnicity will show you this disparity in terms of access to healthcare. Next slide. So on one of the prior slides, it noted that our healthcare system kind of continued without any sort of significant developments until 2010, when President Obama was able to champion the Patient Protection and Affordable Care Act. And the ACA has really been a significant advancement towards health equity for our country and specifically for people of color. And so this just kind of outlines some of the major provisions of the ACA that have gained popularity over the years. and we have to note that the sort of labeling of the Affordable Care Act as Obamacare is a function of racism. The parties that was opposed to the Affordable Care Act really wanted to tap into this anti-Obama sentiment that many people held for maybe because they were not in agreement with policies, but more so because of race. And so we know that that had to be a factor because many legislators or Congress people, when they were going to vote on the Affordable Care Act, noted racial epithets were being hurled at them as they were walking through the crowd to make this historic vote. So race was definitely infused into the Affordable Care Act from the very beginning. But that really overshadows the more important points, which is that the provisions of the ACA have really benefited a lot of people. And if it were struck down, many people would lose coverage and lose access to the health insurance that they need in order to be healthy and to control those healthcare costs. And so we have been pushing to protect the Affordable Care Act as a tool to advance health equity. And specifically, the provision for Medicaid expansion would be lost if the Affordable Care Act was struck down. Next slide. So I'll just note that since this map was done, 2 more states have voted to expand Medicaid. They're Oklahoma and Missouri. But you'll note that a majority of the 12 remaining states that have not expanded are in the South. And that's significant because the South is home to 58% of this country's entire Black population. And so this map indicates in the darker blue shaded states, the higher percentage of Black people living in those states. And so the refusal to expand Medicaid has direct racial implications for our state and others that refuse to expand. Next slide. So of course, Tennessee is one of those 12 states that haven't expanded. And the Tennessee Justice Center, in a coalition with several other organizations, has been leading the advocacy efforts for years to bring Medicaid expansion to our state. We've been really highlighting what we lose by not expanding and what we would gain if we did expand. And so part of, my sort of call to action is to start really highlighting the impact for people of color, especially at a time when racial tensions are more prominent in our discussions. We really need to start connecting healthcare justice to racial justice in these conversations. There's a large body of research that demonstrates that Medicaid expansion has improved access to care, utilization of services, affordability of care, financial security, and other benefits for low-income people who are disproportionately people of color. And some recent analysis show that expansion is associated with decreased mortality overall, and for certain specific conditions, in reductions in rates of food insecurity, poverty, home evictions, and improvements in measures of self-reported health and healthy behaviors. All of these benefits would flow to our state's minority population and would help reduce health disparities, which is crucial to address the ongoing pandemic and to prepare for the next public health crisis. Next slide. So I invite you to visit this webpage for more information. Also there, you'll find a link to the Rooted in Racism paper that we published a couple of months ago that really goes into more detail about the role of racism in our health disparities and in the historical context for how we ended up in this situation. So thank you so much. You can go ahead and advance to the last one. Thanks for having me, and I'd be glad to take any questions.
Thank you so much for that amazing presentation, Kanika. That really laid out, so many different things. So everyone, please put your questions for Kanika in the chat. Several comments saying what an excellent presentation, and thank you for that.
Thank you. There's so much to this. I was trying to be mindful of time, so I'm sorry if I went over.
So one thing that you laid out in part of your talk is some of the criticisms, and particularly, the socialism criticism of any form of health coverage expansion and things like that. I was wondering how you personally address those criticisms, and particularly, with aspects of how to reframe that conversation on the health equity piece of what expansion would mean.
Yeah, I think I may have included this in the paper, but this idea of socialism is really interesting to me because our country is okay with socialism in certain aspects. Specifically in our healthcare system, people would be surprised to learn that our healthcare system is already largely socialized, but it's socialized in the context of tax subsidies that are provided to employers for providing health insurance. There's billions of dollars in tax revenue that are foregone because of the system that has been set up with employer-sponsored insurance. But nobody's attacking that. Nobody's attacking the efficiency of those programs that really incentivize overspending and increased prices rather than the efficiency of Medicaid. For all of its faults, it is a lower cost solution for providing health coverage to people, but it's constantly under attack. And I think it's because of the people and the perceptions of the people who benefit from that program. And so I would just say, when you talk about socialism, you really need to understand that we've already embraced socialism. We're just embracing it to the benefit of more wealthy people than lower income people.
Thanks for that answer, Kanika. Tony Gar asks, some states have looked at their budget through the lens of racism. Has Tennessee done this?
I've heard of that in other states, but I'm not aware of Tennessee undertaking any efforts like that. No. And I would be surprised if they did, especially considering the current makeup of our legislature and their resistance to even considering Medicaid expansion, even though the benefits are really quite clear without even considering racial implications.
There's a question, what would this approach mean? I think it's, sort of referring to that idea of looking at these things like the budget through the lens of racism. I think you could expand that to, thinking about what would it mean for a legislator to actually consider racism in making health policy.
Yeah, it would mean that you would do an impact analysis of each policy that you are considering to see how would this benefit people of color in particular, or on the flip side, how would this harm people of color? If there's a disproportionate impact in one way or another, that's something that would be considered as you're making laws and implementing policies. And so with the Medicaid expansion example, if the legislature were to undertake that analysis, they would look at our health disparities. They would look at how Medicaid expansion has addressed health disparities in other states and consider, if we were to move forward with this, there's only upside here. We can really start to address the fact that Tennessee, is ranked 44th in maternal health, and that has a disparate impact on Black women because of those higher rates of maternal mortality. They can look at, the fact that Tennessee is really at the bottom in terms of life expectancies or access to healthcare, et cetera. So considering all those things and how people of color are disproportionately impacted, that would be the analysis that would be a part of considering, is this a policy we should pursue or not?
And in the interest of time, we'll make this our last question. Alan Hall asked, can you address how the Hill-Burton benefited or impacted the for-profit healthcare industry?
Yeah, I mean, Hill-Burton was a significant piece of funding legislation that that really is the genesis of our modern healthcare system in terms of facilities that were able to be built using those federal funds. And those, private facilities, to this day exist and, are kind of the backbone of our healthcare industry. And they largely received free tax money to start hospitals and hospital systems and profit from those that investment of federal dollars, and they were able to profit without really being held accountable to serve the communities and to serve them equally. And so, yeah, the Hill-Burton Act is kind of credited as like the infrastructure of our modern healthcare hospital system.
Thank you again, Kanika. That was a wonderful presentation, and we really appreciate you being here with us today.
Thanks for having me.
Yeah, thank you. So we'll move on now to our third speaker. Our third speaker is Monique Anthony. Monique serves as the Director of the Office of Minority Health and Disparities Elimination at the Tennessee Department of Health. Monique graduated from Spelman College in Atlanta, Georgia, with a Bachelor's of Science in Biology. She earned her master's degree in public health with a concentration in community health and a graduate certificate in epidemiology at East Tennessee State University in Johnson City. In her role at the Department of Health, Monique facilitates and advocates for the development of policies, programs, and services that appropriately respond to population health disparity issues across the state of Tennessee, specifically those of racial and ethnic minority populations. She has led community-based outreach and assessment activities regarding breast cancer, influenza immunizations, and maternal and child health. Thank you for speaking with us today, Monique.
Monique, you are on mute.
Can you hear me now?
There we go. Now we can hear you.
Okay. Okay, thank you. Good morning, everybody, and happy Saturday. Thank you, Jacqueline, Claire, and the Tennessee Healthcare Campaign for inviting me to here this morning. I truly appreciate the context that Jacqueline and Kanika brought to the conversation relative to health disparities and health inequities. Thank you so much, ladies. You all truly set the stage for me to just really share the work that we've been doing here at the Tennessee Department of Health and the Office of Minority Health and Disparities Elimination to combat those factors, the social determinants of health and the historical context and those longstanding barriers that you mentioned in your presentations to eliminate those disparities and inequities. So thank you so much again. Next slide. And so for the Office of Minority Health and Disparities Elimination, we're really here within our agency to empower communities to support optimal health for all, or health equity, and eliminating health disparities for racial, ethnic, and underserved populations. And so we strive to provide that minority perspective for our commissioner and for the offices and divisions throughout our agency, as well as our stakeholders, to provide that minority perspective on those health issues that impact communities of color across the state of Tennessee. Here we have engaged with faith leaders, community leaders, our legislators, and healthcare providers to really provide insight into the health challenges that have been expressed this morning that our communities face, and to help to create innovative solutions around those challenges. And so with that, we serve to be that bridge and a resource to TDH programs for our stakeholders and for the residents of our communities to provide outreach as well. Next slide, please. And so here, moving into the COVID-19, our agency provides data on a daily basis, which is updated every afternoon at 2 p.m. that highlights the picture of health for Tennessee relative to COVID-19. And so what you see here is yesterday's numbers, where we've increased by 666 cases yesterday, 7 deaths, hospitalizations, and over 5,750 tests that were administered as of yesterday. Currently this morning, our office coordinated a COVID testing event that's happening right now over at the Northwest YMCA in North Nashville, where we're continually working to expand COVID testing for our African American and Hispanic communities. And I'll talk a little bit more about that later in the presentation as well. But I also, too, as it relates to these numbers, want to note that as it relates to, as you all may be seeing the rates of hospitalization start to increase again, that the hospitalization totals that you may see on our page are subject to a 24-hour delay as well. Next slide, please. And so we have been having so many conversations with stakeholders and legislators throughout this pandemic, and we receive a lot of questions related to the data and what that looks like for our African American community specifically.
She said,
and so
the GPS told.
Okay, so we are in a process of developing a public-facing dashboard that will be helpful for our stakeholders and for legislators to be able to utilize to help create additional policies and to use to better serve your constituents and the residents that you're serving here in Tennessee. And so here, like I mentioned, this is a snapshot of the data. Now, this data is as of September the 30th. But here, as you can see, we have, as of September 30th, there were 196,139 COVID cases in Tennessee, a rate of 2,872 cases per 100,000 Tennesseans. Additionally, that is 18.17%, or 36,639 of those total COVID cases were reported for Black Tennesseans. That's also a rate of 3,061 cases per 100,000 for Black Tennesseans. And so, according to our estimates, that is 17.1% of our Tennessee population as Blacks. And so, in the left top quadrant of this slide here, we try to summarize the picture of Black cases. And so you see this is the total number of COVID-19 Black cases, our new Black cases for COVID-19, the total number of Black COVID-19 hospitalizations, as well as the total number of deaths. And then also in the italics, light blue italics, you will see where that compares to the overall group of cases, hospitalizations, and deaths. Also to the right, we have the rate of Black cases by zip code in Tennessee. Many of our stakeholders have been looking for more granular data besides the typical county and regional data that we typically release. And so in our attempts to be able to capture those needs of our stakeholders, this is where we are, and hopefully this will better serve our stakeholders to be able to, that will meet your needs for your outreach efforts. Also at the bottom, you'll see the Black case demographics, which is similar to what you typically see on our state page for our statistics, where we have the demographics broken down by age, sex, gender, hospitalizations, and then by the number of cases, deaths, and percentages. You'll also find that we've added a new column relative to the percentage of deaths as well. Next slide, please. And so here is rate comparisons looking at those regions. And here you'll find that in the top left quadrant, we have all races and ethnicities for case rate per 100,000 Tennesseans. In our right top quadrant, we have white cases rates per 100,000 for white Tennesseans. In the lower left quadrant, Black cases rates per 100,000 for Black Tennesseans, and then in the lower right for Hispanic cases per 100,000 Tennesseans. And as you can see here, for the regional perspective, where we typically have our highest population for Blacks here in Tennessee is in our West region. And so you'll see in that top left case rate quadrant, we see the highest rates for Blacks in that West region. For Hispanics, you'll see that you find the highest rates in the Chattanooga-Hamilton area. And then for whites, you'll see those highest rates in the Upper Cumberland region. Next slide, please. And then this is a depiction similar to the race visualizations, but this is specific to our hospitalization rates. And it has the same layout in terms of all hospitalizations, those for whites, Blacks, and Hispanics. Next slide, please. And then here would be for mortality. And again, same format in terms of overall cases for mortality, white mortality, Black, and Hispanic. Next slide, please. So here is a different visualization of our statewide data, giving a comparison of Blacks, Hispanics, and white COVID rates. As you can see, for African Americans, we have 1.5 times higher rates than our white counterparts. For Hispanics, that's 3.2 times higher than our white counterparts. For hospitalizations, African Americans are 2.45 times higher than our white counterparts for hospitalizations, and Hispanics 2.59 times higher. Again, for mortality, as African Americans, we were 1.85 times higher in our mortality than our white counterparts, and for Hispanics, 1.23 times higher. Next slide, please. Here is, you'll see just the Black-white comparison of COVID-19 rates. And it's those same statistics that I was sharing in the previous slide, just giving you a comparison of just the Black-white as it relates to the rates. Next slide, please. And here you'll see the comparison for Hispanics compared to white COVID-19 rates. Next slide. So next, I kind of wanted to share with you our community engagement and outreach efforts. Since April, really, we have strived to work diligently to meet the needs of our community of color in terms of putting out, releasing messaging that will resonate with our communities, and so that they would know that we want to ensure that they have the appropriate resources and information that they can make the best decisions for them and their families relative to their health. As Kanika mentioned earlier, a lot of us in African Americans are those essential workers that have been out here on the front lines throughout this pandemic. And so we want to make sure that we're continuously communicating the right messages and those best practices that they need to stay safe as we work to get through this together. And so with that being said, back in May, we had created and produced 5 major commercials that were released across all major networks here in Tennessee. We produced videos that spoke to the physical distancing without social distancing. We had a commercial that focused on pregnant women and being able to seek care during this time. We also had a commercial that spoke to the resources available across our communities, providing examples and linkages to our pages that spoke to the social services within a given area, what to expect if you have been exposed, what to expect if you tested negative, and several other resources. We also highlighted, again, those essential workers across Tennessee. We asked our partners to submit pictures of themselves and their families, their loved ones who were out there, whether they were bus drivers, who were those that were nurses. We received a great response relative to being able to see the faces of our loved ones out there doing the work necessary to help keep us safe. And then we also focused on the test. There are many, many people that have been in fear and still fearful relative to COVID testing, and we wanted to bring some ease to what that process entailed. And so we created a commercial that talked about the access to testing and demonstrated what you would go through if you were to go to one of the pop-up or surge events that we've been doing across the state. We've also created a task force that we started back in April that has been taking place every single Thursday since then. And initially, this was to really just create, making sure that we were creating accurate and timely information relative to COVID safety, prevention, and disseminating those best practices and promoting access to testing. And since then, our task force has truly evolved to making sure that there are resources that are made available to our members relative to across all agencies, relative to disparities and those resources that will be beneficial to our communities of color across the state. Next slide, please. Some of the conversations that we were having throughout this time that has helped us in terms of how we have had to shift or pivot our messages and to be mindful and stay mindful of what those that we serve are seeing, hearing, and feeling themselves. And that has been really trying to share the message. Kanika said it best earlier when she mentioned how the myths that African Americans would not get COVID, and that, as we all know, is not true. COVID-19 does not discriminate, and it hasn't discriminated. And so just making sure that people know what that entails for their health. Many of us in the African American community have pre-existing conditions and other underlying conditions that are exacerbated as a result of COVID as well. And this is information that our communities need to be aware of and able to take the appropriate action to make sure that they're staying safe. Also, there has been a lot of effort to make sure that the resources that we're providing and the messaging speak to those that are on the front lines that feel that if they were to be tested and tested positive, that they couldn't afford to stay at home because of the period of time that's needed to quarantine. There's a lot of messaging that and just conversations that go into what can we do to make residents feel safe, protect themselves, and to protect others if that becomes the case for them. And again, just addressing the misinformation and conspiracy theories, debunking myths related to testing, as well as the fear of deportation from our Hispanic members, and just the mistrust of government as it relates to COVID-19, as it relates to vaccinations and et cetera. Next slide, please. I mentioned earlier that we have been doing COVID testing since early May. And so since then, we have coordinated over 109 events. We've completed over 90 of those events and have tested 14,819 folks who've come out to be tested through these events. We started out in our metros and have expanded out into the rural counties across the state of Tennessee. As we know, when we think about a health outcomes, that no county in a state is the same. And so we have to make sure that we're able to accommodate and attend to the needs of that specific population for that particular area. And so we try to be mindful of that and accommodate to the degree as much as possible to make sure that the communities that we're going into, that they know that this is something that is safe and they know their status. So here's the depiction of those areas that we have been in so far. And again, we are here at the Northwest YMCA this morning as well. Next slide, please. So here I just wanted to highlight some of the visualizations that the CDC has offered as well relative to the risk of COVID-19 and hospitalizations. Here we show where chronic health conditions such as diabetes, increase your risk of being hospitalized from COVID-19. And so also too, you'll see other health conditions such as asthma, hypertension, obesity, kidney disease are depicted here, and your level of risk of getting COVID with those conditions. Next slide, please. And then here also too, we look at as you get older, your risk of being hospitalized or a risk of dying for COVID increases as well. So here's a depiction that highlights that those ages and your risk for hospitalization or death as a result of that. Next slide, please. And then here shows race and ethnicity and the risk markers of other underlying conditions that impact health, including your socioeconomic status, access to health care, and increased exposure to the virus due to your occupation. As we've talked about extensively, those frontline essential and critical infrastructure workers. Next slide, please. And so for these last couple of slides, I just want to talk about some of the next steps and things that we're doing here in the department. And so as we work to advance health equity, Kanika talked about racism, and racism is a public health issue. Many states, as you've seen across the country, have declared racism as a public health issue. And, we consider racism as a public health issue, and we'll go as far as to say racism as a underlying condition as well. Here I highlighted the quote from Dr. Kamara Jones, who is truly someone that I look up to here in this public health field, and has been a trailblazer and leader across our nation relative to public health. Again, we've always looked at addressing social determinants of health, but we haven't made a lot of headway as it relates to the underlying root causes of systemic and structural racism as we work to advance health equity. And so these are some of the things that we are building upon within our office. Next slide, please. And so as we think about achieving and advancing health equity, we are having many conversations. We're talking, we're teaching, we're training, and we're trying to take action. And so thinking about those things that we have on the table right now, as I mentioned earlier, we're doing the weekly task force briefings every Thursday afternoon. We're having targeted communication on our websites, our social media, disseminating information and receiving information from our stakeholders and partners who we value so much. A lot of the work that we've been able to do throughout this year alone, we couldn't have done without the input of and the feedback of our stakeholders, and we appreciate you all so much. We developed sections where we can have anyone who comes to our page be able to submit questions and comments to further the work or to further your work as well. We are incorporating or developing health equity training internally for our internal workforce as well as for our external partners. We have recently had 5 listening sessions relative to vaccinations, and that is just hearing from those in the African American community, whether it was our students from our HBCUs, healthcare providers, faculty, our community-based organizations, and just other community members who we sat down with in the month of September to really get their perspective of their feedback from as African Americans to understand the historical perspective of vaccines and get their insight on to provide insight on access to vaccinations and the best way to communicate vaccine messaging across our minority communities. Also, we work very closely with our historically Black colleges and universities here in Tennessee. We provide funding to Meharry Medical College, to Lane College, to Fisk University, to Lemoyne-Owen, and to, did I forget somebody? To make sure that they have resources to equip their students as ambassadors to develop ways to provide prevention education to decrease the virus transmission on their campuses. We've also expanded our work relative to our partnership with Meharry Medical College and the HBCU Wellness Project to provide prevention education and outreach to educate and inform multicultural, multi-generational communities, including medically underserved, under-resourced populations about the impact of COVID-19 and how to mitigate the further spread of COVID-19. And several other activities that we're working with our students at the HBCUs to address COVID and other barriers to health disparities on their campuses and their surrounding communities. Also, we've instituted Lunch and Learns most recently. Kanika mentioned earlier about redlining. We had a conversation a few weeks ago about segregation in housing and redlining. And 2 weeks ago, we had a conversation about trauma in the Black community. This upcoming Tuesday, we're going to continue that conversation about trauma and talk about how trauma and workplace strategies to address mental health this upcoming Tuesday during the 12 to 1 o'clock hour during the lunch hour. So hopefully you all will be able to join us for that as well. So there's several things that we're working on, even strategically internally with our agency as a whole, to advance equity as it relates to access to care and other focus areas and objectives that speak to education, engagement, and policy change. And I will stop there. I think my next slide is just the last slide with my contact information.
Thank you so much, Monique. That was a really informative and data-rich presentation. Thank you for sharing that with us. So everyone can continue to put their questions for Monique in the chat box. We have a question though. Have you been able to look at this data for COVID by the person's uninsurance or lack of health insurance status? You're muted again, Monique.
Sorry, can you hear me still?
Yes.
Okay. Yes, so we have been working with our sister agencies and the Department of ECD, Economic Community Development, and others to try to look at the statistics relative to that. I don't have those numbers with me now, but if anyone is interested in those particular statistics, I'll be sure to provide that information for you.
Related, is the information that you presented here today available on the state website for your office?
Yes, so we have the our state office website as well as our agency site. A lot of the information that we post, we try to post to the main TDH COVID page, which I can place our link into the chat box, as well as our office website page. But yes, if there's any information that you don't see on our website that you would like to know, please reach out to me in my office, and we'll do our best to make sure that we can get that information for you.
Thank you, Monique. And so Tony Gar also wants to ask the same question that he asked to Kanika, in terms of some states have looked at their budget and their policies through the lens of racism. And, you know, same question, has Tennessee been able to do this? And particularly, have any of the state legislators contacted you or your office to ask for a comment on budget items that are racist?
Well, I would say that I would say no at this time in terms of the state as a whole. I think that as we're continuing to have conversations with our legislators and our governor, that hopefully there will be more opportunities for us to incorporate this into the budget. I would say that for me specifically in the Office of Minority Health, we have been having conversations relative to that and trying to receive additional funds that will go even more directly than the state funds that we currently have specifically to minority communities.
Thank you so much for that answer, Monique. And thank you for posting the state health department website there. I think there are no more questions for you. So thank you again for that wonderful presentation and for joining us here today.
Thank you.
So we're gonna move on now and show a quick video clip.
Before we do this, we are having to make a change in our schedule. Just as the year has taught us, you have to be ready for anything and be ready to change at any time. So we're adapting our schedule, and I just want to pass it over to Shonda Dunn before we show the video.
Hello, everyone. Before we actually play this video, I just wanted to give a really quick background on why we are choosing to show this video. As Claire mentioned before the start of all of the presentations, where we are acknowledging the wisdom and knowledge of the three women who presented that information, we wanted to bring to light the reason behind why we feel as though discussing health equity and racism is essential to the movement of healthcare, as well as to all of the movements in social justice. After this video is shown, I encourage you all to engage in critical dialogue within your workplace and within yourselves, and to keep persisting as we move forward. Thank you.
George Floyd
repeatedly told the officers that he could not breathe after an officer knelt on his neck.
The family of George Floyd held a memorial in his memory.
My brother's gone, but the Floyd name still lives on.
George Floyd, you are gone but not forgotten. Because of you, we've come together.
This is for George Floyd.
It's all right to be angry, but we're going to take our anger and our indignation and turn it into energy. George Floyd! George Floyd!
To march. To dance. To kneel. To be quiet. We're saying your name. We're saying their names.
Say her name. Say her name.
We're being loud.
Hands up! Don't shoot! Hands up! Don't shoot!
We're being brave. We're laughing. We're crying. We're getting engaged. We're getting married. We're changing the world.
We soldiers, man. Let's stop hurting each other and let's get it right, man. Today is the day we're gonna stand up for our community, man. If we could do this, we could do more. We just gotta continue on pushing and don't give up.
He did what?
Dad changed the world.
Daddy changed the world.
So I will take the opportunity just to follow that up. A hard thing to follow up, but I truly hope that that video, if not moved you to tears, as I almost was, made you reflect on something. It made you think about something that you can do, that you can begin talking about, to begin action, to begin making change for a better tomorrow, for all of us and for our entire community, especially those who are Black members in our lives, in our families, and our those are our friends that we know, but especially for those Black lives. So I do want to just mention we will not have time to do our breakout rooms. So at this time, I'm going to pass it over to Claire Sullivan to close this out.
Thank you all so very much. I really, regret that we can't have those discussions, but maybe we can figure out a way to continue this conversation with future webinars. Just a reminder, speaking about change, one way we can make that happen is to be sure that we vote and that everyone we know is voting. I know so many of us have had a very busy October, not only, dealing with, COVID and healthcare and future of the ACA, but, the need to be engaged in this election. And I know you all have worked super hard, and I really appreciate it. I just want to skip to the slide on evaluation. And I want to leave you with this. I'm going to, if you don't mind, participants, email out some information to you about the coming sessions. I just don't want to, take up more of your time now, but I do want to really encourage you to evaluate this session and give us your feedback and tell us what, how you would like us to follow this up. You can do that by, scanning this code. I can never remember the initials for it. But also, we will be sending out information in the chat box for the evaluation link. And we will have the slides from this presentation posted on our website. Eventually, we'll get the video up there too, so that we can share it with others. And as I said, continue this conversation and, really think about how we can, integrate this, this motivation and energy into the work that we're doing on healthcare in general and on bringing equity to our healthcare system. Also wanted to just remind you that, thanks to our sponsors who have made it possible for us to provide this conference series to you without any registration fees or anything, that, we always appreciate donations, and we'll invest those donations in this ongoing work. Thank you so much. Jacqueline, do you want to say anything else?
No, I'm dropping the evaluation link in the chat now, so apologize for the delay on that.
Allie, could you put up the website information for people so they can, please feel free to go here to, get more information about the upcoming sessions and about the rest of our work. And thank you all for this really amazing presentation, and so appreciate it.